we'll make a start. So Michelle had just introduced herself. Can we go to David?
Hello, I'm David Emerson. I'm the secondary care doctor on the governing body of the CCG.
And then if we can go to Karen.
Yeah, I'm Karen Hawkins. I'm the Director of Commissioning for the CCG with the responsibility for primary care.
Sue?
Oh, hi, I'm Sue Greaves. I'm the Head of Commissioning and Strategy for Primary Care working for the CCG. And
then I've got Shane next.
Yeah, hi, I'm Shane Moore. I'm the leader of Hartlepool Council and the chair of the Health and Wellbeing Board here in Hartlepool.
Brilliant, lovely to have you, Shane. Mark?
Hello, just checking you can hear me okay.
You're very quiet.
I do have an issue with sound sometimes. Mark Pickering, Chief Finance Officer.
Thanks, Mark. Janice?
Yeah, I'm Janice Foster. I'm Chief Executive of Cleveland Local Medical Committee.
And Becky?
Hi everyone, I'm Becky Warden, Primary Care Commissioner and Lead for the CCG.
And then Lisa?
Hi, Lisa Bosworth, Project Lead for Healthwatch South Tees.
Lovely, welcome Lisa. And then Graham?
Hi, yes, I'm Graham Earl. I am the Digital and Estates Lead for Tees Valley CCG.
And Hannah?
Hi, I'm Hannah Heron, Finance Manager for NHS England covering Tees Valley CCG.
Lovely. Well, we've tested everybody's mic. Everybody's mic's working, so if you bear with me and I'll make a start. I'm just trying to do a bit of juggling with stuff. So if I can welcome you to the meeting. The meeting is going to be video recorded, so I hope that that's okay with everybody, and it will be made available publicly on our website afterwards. Can I just remind people to put the mobile phones on silent, use the Tees Valley background if you can, but I think there's a few of us struggling with that. I always think the meetings are a bit more interesting sometimes as well when everybody's got the homes on show. To minimise the noise, can you go on mute unless you're actually speaking? And can you raise your hand if you wish to participate? Can you use the raise hand button if you can? Because I'm sliding across the screen, but if I miss a question from somebody, if somebody else can see that they've got the hand up, please feel free to interrupt so that I catch everybody. And then obviously if you have to leave your seat, if you can put your video on off, that would be great. So if we can make a start on the actual business, we have got some apologies for absence. Janet Walker has given her apologies. Dr. Richard Harker and Ali Tamasibi has given his apologies as well. The meeting is quorate. And does anybody want to notify me of any other business for this particular meeting? No.
Caroline,
yeah. Karen, yeah.
I was going to pick up under any other business, just an update in relation to a recent report that's been published.
Okay, that's brilliant, Karen. Thank you very much. So if we can go on to the declarations of interest, if anybody's got any additional declarations that they want to share with us, we can get them recorded. There are a few conflicts of interest throughout the meeting, but I'll address those as we're going. We don't have to ask anybody to leave, but some of the different reports have got different conflicts on. So in terms of the minutes of the previous meeting held on the 20th of October, are those that were present happy to confirm that they're a true record? Yeah, seeing lots of nods there. Yeah, smashing. And then there wasn't any items for matters arising on the action log. Has anybody got any items that they do want to raise from the minutes? I don't think there was any for that particular meeting. No, we okay with that? Lovely. So if we can go on to item 40 then, this item is for discussion. It's the primary care budget, and Hannah is going to take us through the report. Over to you, Hannah.
Oh, that's a start. I've managed to get myself off mute. So that's, I love Zoom. Just so, I think Mark reported at the last PCC that we were going to be due for a change. of budgets going forward because we were going past the 6 month stage. So now we are on month 7, and we have had full allocations in for the year. So this is the first month we've actually had full a year's worth of budget, which is very unusual. So if you compare back to previous reports, you'll see that obviously the figures have gone up quite considerably because we've now got 12 months worth in there. Just trying to get my head into it all, really. There is for month 7 we were still awaiting, unfortunately, when we closed month 7, what we call month 6 retrospective allocations. So that was in the first 6 months where we were showing a deficit and we had pressures. These were being funded via the sort of the COVID top up and additional allocations funding, and that was a figure of 845,000. And you'll see on the table, it's one of the bottom figures that you can see that 845 on there. So it looks like we have a pressure of 845,000. However, that funding did come in month 8. So when you get the next set of reports, that's now nil. So actually, if you take that out of the equation, we were basically a break-even position. So we had, all our years funding in, we had all our contracts amounts covered from the original uplift, and we're looking for the first time for a while in a reasonable position as far as what we've got budget for. I think really the one thing that we need to sort of raise is around the risk, and I've put quite a bit of information in the risk on the paper around an element around potential management charges that we may get charged to us from CHP and property services. It's kind of work in progress at the moment, and that's why we've put it on the risk, and it's not actually factored into the reports because we're aware that potentially we may be charged a 5% management fee that should be payable by us for properties that are within CHP buildings or NHS PS ones. It's a lot of hearsay at the moment, and we're trying to work our way through it, but because it could be a significant figure, we wanted to raise it and put it on the risk. On as a risk, so that you are aware of that. I've kind of done a bit of very much finger in the air around what potentially those charges may look like, and the issue we've got is that there'll be arrears payments to these as well. So this could be backdated for a number of years, 2 to 3 years. And that's why I've got in the region of 250 to 500,000. So we look from a budget point of view, we look okay. We're at break even. We've got our LIS covered. We've got our contracts covered. But this is sort of hanging over us. We've also got it's the era of premises, I'm afraid, guys. We've also got an awful lot of practices that have had rent reviews recently, and quite a lot of those are backdated rent reviews. So we're seeing backdated sort of a number of reviews where they haven't actioned them in the past. They're now being actioned, and we're getting stung by quite hefty uplifts. So there's another risk around there. And what we haven't got within our budgets is any contingency. We could cover all of the basic costs, but we haven't got any contingency in there. So I'm nervous around where this is going to go through this year. We're just undertaking a piece of work to look at the additional costs we're seeing in the last couple of months around premises, and so we can start factoring that in. But there's a nervousness there, definitely. So again, it's obviously I've raised that on the risks element. And I think that's probably about it. I don't know if Mark's got anything that he wants to add on to that.
Yes, if I can. Can you hear me okay? No?
Very slight, Mark.
Right. Any better? No. I'll do my best. So
yeah.
The point I wanted to make was that there is a risk around premises, and we will consider that alongside the overall CCG position. So there may be some pressure in the delegated budget, but we'll consider that in the CCG position as we move towards the end of the year.
Okay, I think we're going to have to get you a new mic, Mark. Can you not get that signed off? One of the questions that I had, Hannah, was I just wondered, sort of like, because I know that we're really good on audits and everything like that. I just wonder, how does something get thrown in like this and then get backdated, and it could have an impact of potentially £500,000 by being when we've got, everybody looks at our accounts on quite a regular and timely basis. So I'm just thinking, how does that happen?
It's unfortunately with the management fee. So what's been happening with management fee, this has been rumbling on in NHS England. I mean, I can remember having conversations sort of two and a half years ago with sort of heads of primary care nationally around this, when PS and CHP started charging management fee, and whether that was a reimbursable cost or not. And, you know, we said, well, hang on a minute, it's not reimbursable, it's not within the premises directions. It's, you know, it's not a reimbursable. Basically, what if I explain what the management cost is in effect? Sort of, it's basically, if you going back to the old days of PCTs when we had estates departments, you know, everybody within that estates department would do, you know, would look after and manage all of the premises. Well, when we did the reconfiguration, obviously those estates departments vanished, and some people were moved into PS and some into CHP, and they're saying basically that management fee is the fee that would have been the cost of those departments in the past, and it's PS is not, they weren't given any funding for themselves, a bit like I suppose Next in some respects, and they need to charge those costs out, the costs of them and the work they do, to cover off their running costs. And that's really where this management fees come about. Literally just this morning we've, you know, found some information where it says that they won't charge management fee on freehold properties. So if PS own the building and it's a freehold, then there won't be a management fee. Where it will be charged is where we have a lease in place and they have to manage that lease, because obviously there's more work involved with that, and that's where they'll charge it. But it comes back to that point of, is it a reimbursable charge? And as far as we're concerned, it's never been picked up within the premises directions, so it's not reimbursable. So I mean, I've had conversations obviously prior to Mark, when we had Graham living in place, you know, we've talked about it and we're like, well, it's not a reimbursable, it's not in the regs, and it still isn't. But what we're hearing from NHSE sort of premises, you know, the top guys, is that this should be being paid and it should be reimbursable. And what we're saying is well, we want the evidence. Where is the, you know, the gateway letters, the you know, the official documentation to say that actually this is a reimbursable charge? So it's been something that's kind of rumbled on, but it disappears for a year or two. Nothing's ever mentioned about it, and then it rears its head again. So it's kind of, you know, that's really where it comes from. And I don't think there certainly isn't any evidence of official contractual information around it being a reimbursable. But what I've done is I had a conversation with Mark and I'm saying it seems to be gathering more and more noise, and I think we need to be prudent in the fact that if we just carry on thinking it's not going to happen, then it could bite us on the bottom further down the line. We need to start looking at what potentially this is and building that in so we have got some resilience for it.
No,
so that's hence why it's come about.
That's brilliant, Hannah. Thank you very much. Has anybody else got any questions for Hannah? I can't see any hands up on the participants list. Is anybody?
Caroline, sorry,
yeah.
I can't find a hand to put up, so I'm on the screen. I think just in terms of reassuring committee in relation to where we are, and I think committee might not have been able to hear Mark, but we are being really prudent in terms of looking at our budgets, including the overall CCG budget. The reason that they're both elements, both the management costs and the rent reviews, are being flagged at the moment to committee is obviously this committee is responsible for the overall delegated budget of primary care. Therefore, we're flagging both of those risks currently, to one, to be prudent, but two, also to look at what mitigating factors we can put in to assure not only the non-recurrent costs in year, but the recurrent costs going forward when we start to set budgets for next year and we receive our allocation from a delegated perspective. So that's why they're highlighted on the reports currently, because it is an ongoing issue in relation to the management fee, and we need to be prudent about that, and we need to plan ahead should that be realised. And then for the element around rental reviews, that's offered out under the premises regulations. We have to look at that, and we have to be able to plan for that. So Hannah and the team are undertaking a piece of work now, looking at what that means now as of today, and then what that means in the future when we receive our allocation. But we'll need to look at that in the overarching CCG allocation as well, I think is what Mark was picking up in terms of managing the risk. But it would not be correct not to inform the committee at this stage of those risks as we move forward.
No, that's brilliant, Karen. Thank you very much for that. Anybody else got any other questions? No? Oh, so are we okay then? The ask of that particular report is to consider the content of the report. So I think we've had a good discussion about that, and we're happy to accept that report. Yeah, lots of nods. Lovely, thanks, David. If we can go on to item 41 then, and that is COVID-19 response primary care update, and Sue is going to take us through this report. Over to you, Sue.
Thank you, Caroline. So this is the regular primary care response update to committee. In terms of the branch closures, the committee ratified four branch closures at the October meeting. We haven't received any further requests since that last meeting, any further new requests. But I would like to request committee to ratify the continued closure of Park and Thorntree branch at North Ormsby to the end of December, because they have been using that for flu vaccinations, and it is being considered as a designated site for the COVID vaccinations as well. But if it's not approved, then they will be looking to reopen probably in the new year. And also the continued closure of Linthorpe branch at North Ormsby to the end of March next year. That is also a designated site for COVID vaccinations. But if that is not approved, if that doesn't progress, then their workforce issues are likely to continue into the new year. So really to approve that to the end of March. In terms of the COVID virtual ward, as I reported at the last meeting, we were part of a national pilot in terms of the COVID virtual wards. That was monitoring patients, COVID positive patients in the community. That pilot was reviewed nationally, and it is now being rolled out across the country, renamed Oximetry at Home. I think one of the biggest discussions that they had nationally was what to call it. Oximetry at Home is the new name. Referral criteria has been agreed, which in a nutshell, not quite as simple, but in a nutshell, it's anyone COVID positive or COVID symptomatic who is waiting the results of a test, over 65, and those under 65 with significant comorbidities. Slightly more complicated than that, but that's it in a nutshell. The three GP federations are working collaboratively to deliver the remote monitoring element of the service, and we've commissioned that initially until the end of March next year. And patients who require face-to-face consultations will be referred into the hot clinics as they were during the pilot. In terms of the COVID vaccination programme, that's been a lot of work in a very short space of time, which and is continuing. We've undertaken a lot of work with the PCNs across the Tees Valley in preparation for the COVID vaccination programme. all PCNs submitted applications for a designated site from which the PCN would be able to deliver the vaccinations from, and a small team of myself, Becky, who is in the meeting today, Janice and Caroline as well, who were all involved in this meeting, were involved in the evaluation of applications against the national criteria. I'm not going to go through that because it's quite lengthy, but it is it's included in the tables on page 20 to 22. All of the sites, including 3 non-GP premises, were recommended for approval to NHS England, and were all approved towards the end of November and by the 4th of December. All practices have subsequently signed up to the enhanced service, and I do want to thank Janice and Caroline for their input into that evaluation process. Couldn't have done it without you, especially, and you know, it was at such short notice, and it was 2 days out of our life. That was really a really intense process. And also to recognise the efforts of all the practices, and that all 80 practices and PCNs, in terms of the work that they did in identifying suitable premises and commencing the planning across all practices, not only in the logistics of how to deliver that, but also in terms of how they were going to maintain existing services at the same time. Since that paper was written, there is a slight update, because we have had 2 PCNs have now started. They were in wave 1, so they've actually had deliveries and commenced giving the vaccines. I think wave 2, I know Becky's on the call, so she might correct me if I'm wrong, but wave 2 starts later this week and wave 3 next week. So yeah, significant amount of work has been undertaken, and all been very, very positive. Any questions?
That was excellent, Sue. I was just going to say the same actually to you and Becky, because that was a tremendous piece of work pulled together on very short time scales, and still a desire to involve myself and Janice as well. So that was really well done. It was a great bit of work. Has anybody got any questions for Sue? Let's have a look. Can't see
David.
Yeah.
Yes, thanks. Yes, thanks for that report. Just wondering about the COVID vaccination. Is it being, and would it be adequately funded? It's obviously going to take a lot of staff time, both the planning and the administration of the vaccines.
Yes, yeah, the practices are being funded nationally. It's, I want to say £12.56. That sounds about right to me for each vaccine. Obviously, there's 2 vaccinations per patient, so it's £25.16 or something for the 2. There is funding through GP support fund as well. So yes, we believe that that practices will be adequately funded in terms of providing the vaccination program.
Thank you.
Jane, I saw you had your hand up.
Yeah, thank you. Not a question, actually, just a bit of praise. Surprisingly, I've had a number of people get in touch with me to say how well the virtual ward worked. One of them was actually Ben Houchin. His wife was a patient in the virtual ward, and it worked really, really well. So I just wanted to pass on the good comments.
I'll pass that on to the team. Thank you very much.
That's great. Thank you very much for sharing that, Shane. That's lovely. Right, if people are happy then to, we're being asked to note the contents of the paper and ratify.
Sorry, there's some other hands. There's some other hands up. Janice has got her hand up, and Michelle had her hand up as well.
Oh, I'm awfully sorry. Go to Janice.
I couldn't see them.
Michelle.
I can only see so many people on the screen.
I've only
Well,
got
I usually
4 on
have
the
the little
screen.
hand raise symbol, but there's not one there today. I don't know where
No,
it's gone.
I can't find mine either. Sorry, Janice. Go ahead.
Weird. No, no problem. It was really just to say, I think it's important to mention, I know there has been thanks given to practices and CCG there and to ourselves, but I just think we need to recognise, and it's to come back to David's point about, you know, is it adequately funded, etc. I think everybody locally has worked really, really hard and pulled together against what are very difficult criteria and circumstances to try and address this COVID vaccination programme. And I think it's credit to everybody in doing that. I think any failures or issues that come about as a consequence of the COVID programme has not been due to any lack of work on the ground or lack of funding or support from the CCG. Whether it's adequately funded, I think, is a question nationally, and only the national team can decide that. It's what's been negotiated nationally and wasn't within the CCG gift. So I just wouldn't want it to come back that, yes, it's adequately funded, everything's rosy. As far as the CCG is concerned, I have no doubts that the CCG has done absolutely everything that they possibly could as primary care to try and deliver this and deliver it successfully. So I just think it was important to note that and say it's credit to everybody, and the rest of it is kind of in national hands as opposed to within the local gift.
Brilliant. Thanks very much for that, Janice. That's smashing. And then over to Michelle.
Yeah, mine's more praise as well. It just, I mean, I'm just in awe of primary care at the moment. I mean, everything seems to have been thrown at them, but from a patient and public point of view, it feels really safe, as if you're in safe hands. Yes, there are frustrations within the system, but I think for the vaccinations and the way that it's all been coordinated, I think, you know, we have been hearing a lot of praise about it. I'm also wondering, with the comms to patients, are each PCN doing their own comms, or is there going to be a rollout? Because I know that there's a lot of people that are ringing up the primary care, their own GP practices saying, you know, can I have my vaccination? And the GP practices know which people to get in touch with to sort that out, but it just seems that the public aren't really quite sure at the moment.
So, Michelle, I can pick up on that around the comms for COVID vaccination. All of the comms are being managed nationally and obviously centrally, and then down to region. We are communicating with patients currently, and we've put out some notices on the CCG social media channels and in public not to contact their own practices at this time. Practices who are involved and those designated sites that are involved in the programme will automatically recall patients, and they will receive notification of that at that time. Now, the reason that is because the vaccination programme has been undertaken in different waves, and some practices, due to logistics and some changes, may move waves. So that's why it hasn't gone out. We haven't gone out and said this is the site that would be delivering, because it's an existing working practice in most cases, and we don't want the impact to be on general practice and delivery of routine care alongside of the programme. But also just to make sure that we're not sending mixed messages if for example, that their designated site might change in terms of waves and dates. So as soon as they have received notification, the designated sites from NHS England as to when they'll receive their vaccines, then that's when the patient information is pushed out through patient leaflets and through telephone contact directly with those sites.
No, that's really helpful. Thanks, Karen.
Brilliant. I'm going to move it to the recommendation, if that's okay, because I'm conscious that we have got a schedule. So we're asked to note the content of the report, but also to ratify the continued closure of the branch surgeries and the review dates as outlined. So is everybody happy to agree that recommendation? Yeah?
Yes.
Yeah, lovely. That's great. I can see a lot of nodding heads. Yeah, that's smashing.
Okay.
If I can move on to the next item, then this is item 42, and Jackie is going to take us through this, and that's the primary care risk overview. So I'll pass over to Jackie. Is Jackie on the call?
Caroline, I'll pick this up on behalf of Jackie, so I actually said I would do it for her. And as it's something that the primary care committee will already be cited on, it's just to provide you with an overview of the primary care risk overview. This is to ensure that committee members are aware of the risks that we have on our corporate risk register in relation to primary care. The committee members today are asked to review the risks on the risk register and consider any areas that require more detailed consideration, which could be undertaken through a deep dive, and to also note and comment on the emerging developing risks that we will be putting onto the risk register as we go forward. So committee members will be aware that the currently includes 3 risks. You've seen these risks before, and the mitigating factors that have been identified to try and reduce the likelihood of these risks occurring. And there are 3 additional risks that we've included within the paper that we are considering to include within the next report that would be provided to committee in relation to assuring the committee of the mitigating actions that are being taken to reduce the risk to the CCG. So you'll see in terms of the risks 1, 3 and 7, all of those relate to different elements of CQC ratings and those practices that might require improvement from CQC. If we're able to shortages and failure of infrastructure. And the last risk was around if the team, the primary care team itself, was significantly depleted, because we do support practices in managing the action plans that are developed, as you'll have seen through previous reports to committee, for those practices that may be rated inadequate. So I don't intend to go into the detail of the risks today, I'm conscious of time, but the documents have been provided with the detail and the mitigating factor. But I think it is important to outline to committee that we have had discussions through the CCG's executive and also through this committee in the past in relation to some additional areas that we feel it's necessary to consider and add to the risk register. So the first one that we were considering and will be adding is the primary care networks not attracting a suitable workforce in line with the planned recruitment. Now, although we will be able to mitigate a number of those areas in relation to the support that can be provided to the primary care networks, we won't be able to remove all risks, and there will be a residual risk with that one, which we'll provide in more detail at the next committee. There is also considerations being provided in relation to one of the risks that we've identified previously, and as I outlined above in the section on TV001. And should a practice receive a CQC rating of required improvement or inadequate, and the registration being suspended or cancelled, that could result in the risk to continuity of care of patients, the risk to accessibility, the impact on other practices should a dispersal be required, and also the impact in relation to the financial risk to the CCG should we end up in a situation where that risk has been realised. Again, we're working to produce the report in the risk in the profile of the risk, so that you can see what actions are being taken to mitigate that. But in terms of reassuring the committee, we're already working. Some of these are not only corporate risks, but they result in operational risks. So we're already working through ensuring that we're mitigating that where these may arise for practices as we currently stand. So what we're asking the committee is to having already undertaken the review of the risk register, consider any areas that you feel as a committee that you would require more detailed information or consideration on, and then to also note the developing risks that were outlined.
That's smashing, Karen. Thanks for taking us through that. Just before I pass on to David, what Hannah said earlier, that risk that's been identified about various practices getting their rents reviewed and the implications of that, would that need to go on here?
I think that's covered under the financial risks in the financial risks that Mark covers.
Okay, already. Yeah, that's
what we've tried to do, Caroline, and for other committee members, is to make sure that we don't duplicate corporate risks as well. So where we work across portfolios, that if it's a financial risk and we're picking it up, it gets picked up through the finance risks. And then if it's a corporate risk sitting with primary care itself, that it would be sat in primary care, so that we don't end up with an ever increasing risk register where there's duplication and confusion. And I think what's really important is we don't confuse who's responsible for the risks and actually how we're mitigating the actions, so that we don't realise those risks as well.
That's great to hear. That's smashing. David, I can see you've got your hand up.
Yeah, thanks, Karen, for that report. I think it would be helpful subsequently to hear more about workforce on a Tees Valley basis, because I think most of us are aware that attracting particularly medical workforce to the Tees Valley has been difficult over the years. It was a big disappointment when Durham University moved the preclinical campus from Queen's Campus in Stockton to Durham, as originally that medical school was set up to try to attract doctors to remain in the Tees Valley after they qualified. So that is one loss. And I think more detail about sort of these expected shortfalls due to retirement and other reasons why people are likely to move away, both from medical, nursing and AHP posts, and likely ability to recruit, and looking at things like the enhanced retention scheme, and what we're really looking for on a Tees Valley basis. It's great all the national work that's being done, but there's always the concern if more money is set up and more jobs are available in the rest of the country, then health staff have more choice where they're going to work. So I think sort of focus for the Tees Valley workforce would be really helpful. Thanks.
Thanks, David. What I would suggest, if it's agreeable from committee, is rather than that be picked up under the risk, that we provide a report that would be supplemented by NHS England, Health Education North East, and also the training hub in relation to the workforce across primary care, and the mitigating actions in terms of the actions that are being taken across the whole of the workforce, rather than it being a particular risk linked to the PCN requirements that we outlined, which are specific to the additional role reimbursement scheme and recruitment to that. And I think what you may be asking for, and correct me if I'm wrong, is a more detailed report in terms of what our workforce is across primary care and what is in place to help support recruitment of.
Yes, I think both recruitment and retention and expected retirements, etc., would be really helpful. Thanks.
Yeah, we'll pick that up, David, with Health Education North East as well.
Brilliant. That's great. Has anybody got any further questions for Karen on this particular report? Janice, I can see your hand up.
Yeah, it was just to say I completely agree, and I think it's good that the primary care network ARRS is being picked up on the risk register. It does kind of link into number 3, the TV0003, because obviously it does impact on the workforce as a whole, because the ARRS workforce is to complement the practice workforce. So I don't know if the two do link together, but I think it is right that it's been picked up. My question, and one of the things I had, and it kind of adds on a little bit from what David was saying, is I noticed that the number 3 has been downgraded in terms of a risk, so that it seems to have dropped in terms of the risk concerns on that one from 16 to 12, if I'm understanding the numbers correctly. And I was just trying to understand the reason for the dropping of that, given the increased risks that we're experiencing around staff sickness and staff shortages, not necessarily because they're leaving the workforce and retiring and stock shortages for that reason, but more around COVID, isolation, and then sickness due to stress, etc. And we did a regional LMC workforce survey that highlighted some quite big risks that we have coming up in terms of workforce, people leaving, the morale being incredibly low. So I think it was just to try and understand the rationale as to why that's dropped at this moment in time, and how we've reached that decision, really.
Sorry, Janice, we lost you halfway through there. Was it 0023?
It's the one that you've pulled out on the bullet points about the sustainability of primary care, and it talks about workforce, etc. in there, and able to provide long-term sustainable quality. It's TV, and it's on your on point 2, so, where you've got existing risks, it's the second risk down.
So the reason that we downgraded it, it's not, obviously it's still on the risk register, was because at the time so this has been on the risk register for some time, but at the time we weren't collecting the information in relation to the national workforce system. We didn't have the processes in place that we now have in place around practices reporting the workforce issues to us. So the risk is still there and it's still high. We just feel that it's lower now because of the systems and the processes that we've put in place to better understand what that risk is and how we can support practices to try and mitigate that as we move forward.
That okay? Yeah.
Yeah, that makes sense as the rationale for lowering it. Like I say, it just didn't reflect how it was feeling on the ground and the surveys that we were having, but as an explanation for lowering it, that makes perfect sense.
Okay, that's smashing, folks. If people are okay, because I am conscious of time, if we can, I think we've had a good discussion around that particular report, and we've given some feedback to Karen. So if we're happy to accept the recommendations on there, which is review the risks on the risk register, consider any areas that require more detailed consideration through a deep dive, and note and comment on the emerging and developing risks. I think we've done that satisfactorily. If we can move on now, the next items are for information. So we're on to item 43, and that's the primary care networks 1 year on. And Karen's going to take us through this report, but I think before she does, this is a cracking piece of work. When I've read the report, there's just so many examples in there of partnership working at its best. So it was a really good report. When I read through it, I was really impressed with it. So well done to everybody who's been involved in pulling that together, especially in the current climate. So over to you, Karen.
Great, thanks, Caroline. I'm going to introduce the item, and then Becky is going to pick it up. Becky is the author of the report along with other members of the team. And I think the reason I wanted to introduce it is probably echoing some of the comments that you've made already around the work that's been undertaken in this year. I'm immensely proud of both the primary care networks and our team and member practices in relation to the hard work that they've undertaken. I think in terms of where we are with the COVID pandemic, whilst transformation has still happened through the COVID pandemic, and I know from a public perspective, often it may not have felt like that, but I think we often look at some of the concerns and the issues and within primary care, and I think we need to realise and actually celebrate a lot of the work that's happened across the year at such a difficult time. And the inception of networks was very new to everybody and still new to patients. And I think this will help patients better understand as well what primary care networks are and the type of work that they do, so that we create more public awareness. But certainly, you know, the work that's been undertaken by the Praxis PCN and the team has been excellent. So Becky will pick out some of the key points. I hope that everybody has read the document. And we will be sharing it wider and on some of our social media channels as well. Becky?
Thanks, Karen. Okay, so as Karen mentioned, the purpose of the report is to highlight the progress that's been made across our 80 practices working together as primary care networks in Tees Valley. For anyone on the call who doesn't know what a primary care network is, that is around networks of groups of practices, working as a network together. The first part of the report very much just describes the inception of primary care networks, which went live in July 2019, and the role that they will play in shaping the system and place-based care for patients. I think it's fair to say networks, like all other organisations and ourselves as individuals, have faced challenges during the COVID pandemic, but it's fair to say that the networks have absolutely risen to those challenges and have continued to develop their relationships between practices and across the wider system, to not only develop new ways of working in line with the contract, but also their PCN aspirations for their populations wrapped around those. So in terms of the first section of the report, I won't go into that in much detail other than to say it describes the 14 networks and the patient populations that they cover. It also gives information of the names of the clinical directors who are responsible for developing and implementing the strategic plans, and also lead and support the quality improvement and performance across the networks. As you'll have seen, primary care networks have a number of core deliverables that are set nationally through the GP contract, and those are listed in section 4. And you'll see that they cover a range of things, such as providing extended hours to 100% of the patient population. Prior to primary care networks, we did not have that coverage, but it's great to see that that is now in place. And also developing things such as enhanced health and care homes, which is aligning care homes to primary care networks to provide proactive care in a multidisciplinary approach. And I think that's been particularly important through the pandemic in order to reduce the number of contacts going into care homes, and also have specific point of contact for care homes for any concerns and queries that they have. For any of you that have seen a report that I've sent previously, primary care networks can recruit to additional roles through a national fund, the additional role reimbursement scheme. and that helps them to achieve the requirements of the PCN, but also to create additional capacity in primary care. Table 1 and 2 of the report lists those roles available to primary care networks, and Table 3 shows the numbers of roles recruited to. And just before I came on the call, I did check, because in the report it states 32.52, but we are now at 46.84 whole-time equivalents, and all primary care networks have now at least recruited to one of the additional roles. So over and above the core requirements, PCNs have progressed a number of key initiatives, highlights of which are listed in section 7. And it also describes, I think quite importantly, how PCNs have diversified their way of working throughout the pandemic. Throughout this time, primary care networks have continued to develop their workforce and also their leadership skills, with a number of clinical directors went through the leadership skills programme also during this time. We work very closely with our primary care networks, the LMC and system partners to work in a supportive and collaborative manner. Again, there's a number of highlights included in the report. That includes things such as aligning specific support to our primary care networks, so they have named contacts in the CCG. We've established a number of collaborative meetings to bring the primary care networks and other system partners together. That helps to obviously manage the dialogue and the relationships, but also progress new ways of working and in a consistent manner. We've led and supported on a number of pilots this year, specifically ones to know are the first contact physiotherapy pilot and also mental health practitioner pilots in PCNs. That will help our PCNs to test the new workforce and develop options so they can consider to recruitment to those in future. And we continue to try and provide subject expert guidance to PCNs and other system members on new guidance that comes, which will help hopefully to develop the maturity of our networks and their response to the specific requirements. And then finally, the report very much just summarises the next steps for primary care networks in 2021 and beyond, and how we will continue to support our PCNs to interpret the guidance and respond to the asks. I think it's important to say that obviously those requirements are set nationally, but we will help support and provide advice and guidance on those as we move forward. The report will be published on the CCG website, and we're hoping to share that out with wider system stakeholders, and all primary care networks have also been provided a copy of the report. So I'll probably stop there in terms of summarising the report and just ask if there's any questions of any specific sections of the report that anyone has. Thank you.
Brilliant. Has anybody got any comments or any questions for Karen or Becky?
No. David, and then the other David.
Well, just thank you for the report, and I think probably just to pass on the committee's thanks for all the excellent work that's been done in a short period of time. I think it's tremendous. Well done.
David?
Yeah, thank you. There's something about having a popular name, isn't there, right, as opposed to a common name, David. I think the point was made at the start, but it's really hard at the best of times for people to lift their heads up and just take stock and realise the achievements that's being made. It's ridiculously hard at the moment because of the current situation, Peeling. So actually this is a really good, really timely opportunity just to step back and see the huge amount of progress that's being made. So it's an impressive document at the best of times, but particularly in the current context. It's really good to see this and the progress, and we should step back and consider that and actually celebrate it and thank everybody involved for the progress so far with this. It's still a long journey to go on, but actually this is a really, really good start. So hats off to the PCNs, the practices, hats off to Becky and Karen and the team for supporting on this as well, because it's a really good piece of work that bodes well for the future, I would suggest.
Yeah, it was absolutely brilliant. I'm pleased to see that it is going to be circulated as well, so that a broader audience can see it. Right, so I presume then that we're happy to receive that report. It is for information. Yep, few nods there. Yep. So the next item is international GP recruitment, and that's Sue. Are you there, Sue?
Yeah, sorry.
Yeah, it's okay.
I had to unmute myself. Yeah, sorry, this is a verbal update, which really is to say there is no update. Obviously, this is a scheme that is being run and managed through NHS England. As you know from the last meeting, it was put on hold due to the pandemic. It is still on hold. I included it really because it's part of the annual cycle of business, but I will bring it to the next meeting, and hopefully there will be a further update then.
Brilliant. No, that's absolutely smashing, Sue.
Thank you.
Any questions for Sue or any comments in particular? No. Right, because I am conscious of time, and I know we have got an item of any other business. So if we move on to that, then we're on to any other business now. Karen, you've got an item for us?
Yeah, sorry, Caroline. This was just to update the committee in relation to, you may have seen the Woodside CQC report has been republished. Now, just to remind the committee that Woodside in 2019's October were rated as inadequate by CQC. Progress has been made in the practice over the last year. However, when they were re-inspected, which was a routine inspection undertaken this October, it was identified that there was further concerns, and CQC undertook further enforcement action against the practice. So the report that's been published, which will be shared with committee and for public, it's a timing thing. We weren't able to get it to committee because we weren't clear when it was going to be published, and it was in committee prior to that. That will be provided to committee. I just wanted to reassure committee and members of the public and our stakeholders that the CCG, alongside with the LMC and CQC, are working with the practice to remedy any concerns that have been identified, and the practice are proactively working to remedy those. We will also be attending scrutiny in that area on the 19th of January to provide members with an update in relation to the actions that the CCG is undertaking alongside of the practice to support them in making sure that services are still available and still provided to patients within that area. There was really just a site committee on it because it hasn't been included in the public papers. It will be provided as a report in terms of accessing the CQC report, and to reassure of the actions that are being undertaken at this time.
Okay, thanks for that, Karen. Has anybody got any questions or comments for Karen at this stage? No, I can't see any hands up. Sorry, folks, there's only 4 of you on each screen, and I've got about 6 screens, so I'm scrolling along them all. No, that's smashing, Karen. We'll continue to wait your updates. I know a lot of work has gone into this, as you've previously reported. So thanks for keeping us up in the loop in relation to that. Right. Okay. If I can move on, we haven't actually got any questions from members of the public. None have been sent in. So the next item on the agenda is consideration of any impact on the risk register. I think we've talked about that, haven't we? So we've got that report, so we're going to include those additional risks onto the risk register. But I think we had a good debate about that. Yeah, people okay with that? And then the next item is key items or decisions to report into the next governing body. Obviously, I'll work through that with Karen and make sure that we're in a position to be able to update the governing body next Wednesday. We've got a governing body meeting, haven't we, next Wednesday? Yep, some nods there. So if people are happy with that, I think we've finished. Couple of minutes to go. So that's not too bad. We've got our next meeting on Teams, so I'll just give people the opportunity to have a quick break, and then I'll see you on Teams in a couple of minutes. Okay, thank you, folks.